Hello everyone, and welcome to this week's NDARC webinar. I'm Alice Havard, a researcher at NDARC, and it's my pleasure to be hosting the webinar today. I would like to begin by acknowledging the Bidjigal people as the traditional custodians of the lands from which I'm joining from today. I'm in the NDARC offices at the Health Translation Hub in Randwick. I would also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across the country. We pay our respects to elders past and present and extend that respect to any First Nations people joining the webinar today. So it's my real pleasure today to introduce our speaker, Associate Professor Gillinder Bedi. Jill is Head of Substance Use Research at Orygen and Principal Research Fellow and Associate Professor at the Centre for Youth Mental Health at the University of Melbourne. Jill is also a clinical psychologist at Headspace, treating young people with substance use problems and comorbid mental illness. In today's webinar, Jill will present an overview of her work on the safety, ethics and methodology in research and clinical use of MDMA and psychedelic-assisted psychotherapy for the treatment of mental health conditions. As our expert panelist today, I'm pleased to welcome Dr. Jonathan Brett, who is a senior staff specialist in clinical pharmacology, toxicology and addiction medicine at St Vincent's Hospital, also a clinical toxicologist with the New South Wales Poison Centre and a senior research fellow in the Medicines Intelligence Research Program at UNSW's School of Population Health. And relevant to today's webinar topic, John recently ran a trial of psilocybin-assisted psychotherapy for methamphetamine dependence. Jill and John will take questions from the audience after the presentation. You can log questions for them using the Q&A function at the bottom of your Zoom window. I will now hand over to you now, Jill.
Oops, hi. Thanks, Alice, and thank you all for being here today. So I'm going to talk to you today about MDMA and psychedelic-assisted psychotherapy, although I am going to focus mostly on MDMA because that's really my main area of research expertise. And I'm going to think a little bit about what's happened so far and potential directions for the future, with a focus on some of the work that we've been doing in my group. So I'd also like to acknowledge the traditional custodians of the land, and particularly the land on which this work was done, which is the land of the Wurundjeri people of the Kulin Nation, the very, very beautiful land around the Centre for Youth Mental Health. I pay my respects to elders past and present and extend that respect to any Indigenous people present here today. Also like to acknowledge the many contributions of people with lived and living experience of mental illness, substance use and substance use disorder to this work. We try as much as possible and work with people who have mental ill health and also substance use to inform the work that we're doing. So as I said, I'm going to focus largely today on MDMA-assisted psychotherapy. And the reason for that is partially just that that's kind of my main area of focus and has been for a very long time. And also it is, I would argue, to be the most developed evidence base in the broad field of psychedelic medicine, although that does appear to be changing. We're seeing some of the more classical psychedelic medicine approaches coming forward as well. So MDMA-assisted psychotherapy to date has been tested primarily for post-traumatic stress disorder with a few small studies in other areas. I'll talk a little bit more about how it actually happens, but one thing that's worth noting is that we don't really understand what the mechanism is for MDMA-assisted psychotherapy and how it might help people with post-traumatic stress disorder. So there is this idea that rather than sort of traditional approaches to pharmacotherapy for mental ill health, it's actually a combination of the medication and the psychotherapy that makes the difference. So the MDMA is thought to, in some way, catalyze the normal processes of psychotherapy themselves. There's also the possibility that it might facilitate extinction processes, which are known to occur in treatment of post-traumatic stress disorder. MDMA itself is known to have some fairly unusual effects, interpersonal and pro-social effects, such as increased closeness and trust. And this might be helpful in the psychotherapeutic context. And there's also this very broad idea of neuroplasticity. And so there is this idea that MDMA and classical psychedelics might be something called psychoplastogens, which is essentially substances which increase the brain's capacity to respond to new stimuli. So allowing adaptation in a more rapid timescale than would normally happen. It is a very broad idea, though, and that's why I've got it in inverted commas. So this is just a couple of papers that I did in my postdoctoral research back in the day in Chicago. My early work was really focused on looking at the effects of MDMA on social behavior and response to social stimuli in humans in behavioral and fMRI kind of contexts. And what we showed in these two studies is really that MDMA did produce unusual social effects in humans that we really haven't seen in many other substances. And these are things like increasing this very strong feeling of feeling close to others, feeling loving, feeling playful. And what's interesting about this is that it occurs even in fairly socially isolated environments, such as in an MRI scanner. In terms of this question of whether ecstasy is an empathogen, I always say that it's a pro-social substance. It's not necessarily increasing empathy per se, but it's definitely seems to increase the degree to which people want to approach and engage with other people. So MDMA-assisted psychotherapy typically looks like this. There is some variability in the actual protocols themselves, but most of the studies to date have used something like this. So it's an intensive psychotherapy process that occurs over a 3-month period. There's a period of screening initially, then there's a series of preparation sessions. And the aim of those preparation sessions is for people to become familiarized with the therapists, to start develop a trusting relationship with the therapists, and to really understand what the medication sessions are like and to kind of identify what their goals and intents are for the rest of the therapy. Then there are 2 medication-assisted psychotherapy sessions, and these typically happen about a month apart. And these are kind of the unusual part of this program of psychotherapy. So they typically go for around about 8 hours, so very long period of time to spend with your therapist. And during this period, a range of different things can happen. And this does vary depending on the substance that's being used. So in the case of MDMA, we can actually do more active psychotherapy in these sessions because people retain quite a high degree of sort of awareness and clarity about what is happening, and they're able to engage in more normal psychotherapy activities. For some of the other medications, such as classical psychedelics like psilocybin, 5-MeO-DMT, it's much less possible for people to engage in more sort of normal psychotherapy. So in the period after each of the medication sessions, there's a month where during which there's a period of what's called integration. And the aim of this is really for people to understand and process what happened in the medication-assisted psychotherapy sessions, and then generalize anything that they've learnt from those sessions into their daily life. So integration, both preparation is thought to be very important in terms of supporting people and ensuring a safe outcome in the medication sessions. And integration is considered to be very important in terms of really allowing people to generalize out from those experiences into changes in the real world. So just a brief history of MDMA-assisted psychotherapy. So MDMA was first synthesized in 1912. It wasn't really tested in humans until the 50s, and the first paper that was published on MDMA was actually in 78. Then in the 70s and the 80s, we saw an increasing use of MDMA in the context of psychotherapy, and that was largely on the west coast of the USA. But at the same time, we saw MDMA kind of leak out from the psychotherapeutic context into recreational use. And that coincided with the increase in sort of the rave scene, the Summer of Love in the UK, etc. So there was a massive increase in recreational use, and that caused a response starting in the States. In 1986, the DEA conducted a series of hearings to determine whether or not MDMA would be scheduled as under a poison, and despite a bunch of testimony from therapists saying that it was useful therapeutically, it ended up being scheduled as Schedule 1 at this time. And it was scheduled at a similar level in other countries, including Australia, soon afterwards. So what that high-level scheduling essentially means is that this is considered to be a poison with no accepted medical use. And so that's kind of justifies very, very stringent restrictions on access to the medication and makes research very difficult. So immediately after this scheduling occurred, an organisation called MAPS, or the Multidisciplinary Association of Psychedelic Studies, was founded by someone named Rick Doblin, who was involved in the hearings advocating for MDMA not to be scheduled so restrictively. And MAPS has really led the field in relation to work with MDMA ever since. And so it's important, I guess, to understand the context of what's happened since then, that really MAPS is very much an advocacy movement. It considers itself part of a movement, the psychedelic movement. It's quite countercultural. It's not traditionally scientific. And in many ways, that has led to some of the difficulties that have happened in the last little while. So in 1994, we started seeing phase 1 trials, which are trials happening in healthy humans. So work that's being done really to understand the effects of the medication. And that includes some of the work that I did in the early 2000s with phase 1 studies with healthy people. Then 2011, we saw the first phase 2 randomized control trial happen, and this was of MDMA-assisted psychotherapy for post-traumatic stress disorder, and this was sponsored and run by MAPS. In 2017, the US Food and Drug Administration designated MDMA a breakthrough therapy for post-traumatic stress disorder. And this was considered to be quite important at the time because what it indicated was that this was a potentially promising new treatment for a condition, a serious and life-threatening condition for which existing treatments were inadequate. So this really was a way of the FDA potentially indicating that they were supportive of this treatment and that they potentially might fast track the treatment through the processes of approval. So in 2021 and 2023, we saw the 2 phase 3 studies published, which are essentially studies in patients, again, for post-traumatic stress disorder, but larger studies, which are designed to indicate more conclusively that something is safe and effective. And each of those studies had around 100 patients in them. 2023, based on advocacy from an Australian advocacy group called Mind Medicine Australia, we saw the TGA reschedule MDMA for PTSD and psilocybin for treatment-resistant depression under the authorised prescriber scheme. So authorised psychiatrists can now treat people with MDMA-assisted psychotherapy in Australia. So it was all going along very promisingly until 2024. And then in 2024, we saw a series of things which undermined, I guess, some of this progress. There was a report which highlighted a bunch of methodological issues with the studies that had been published to date. And there were also some real concerns around ethics and adequate disclosure of adverse effects and safety issues in the existing trials to date. And that all culminated in 2024 in the FDA rejecting the application that had been made by MAPS for MDMA-assisted psychotherapy to be approved for the treatment of post-traumatic stress disorder. So that was a bit of a shock for everyone. It really had looked like up until 2024 that was going to sail through the approval processes. Not necessarily because of the strength of the studies, because myself, my group, and many other groups had highlighted some issues that had occurred, that had come up with these studies. But it did just definitely seem like there was going to be an approval forthcoming, and then there wasn't. And that, I'm sure many of the people here today would have seen commentary about that in the news. So it was all a bit shocking to those of us in the field. So I guess I want to talk a little bit about a couple of the things that went wrong and where to from here. I would say that I'm really going to focus on just a couple of main issues, and there were other issues that have been highlighted in relation to the reason that the FDA declined approval. And we've actually written about them in a paper that I haven't actually got on this slideshow, but I can perhaps send around afterwards if people would be interested in this. So the two major concerns that were raised in the advisory committee meeting that happened before the FDA approval and advised the FDA approval were issues around side effects and safety monitoring and something called functional unblinding, which I will talk a little bit about in a second. And so what I'm going to do is sort of talk about, I guess, where we're at with both of these issues and why they are potentially problematic, and then some ways that we might be able to think about going forward to address some of these issues in future research. So, side effects of MDMA-assisted psychotherapy. So this is super important, but sometimes I feel like I have to clarify why it is actually important. At a basic level, we know that patients and clinicians need to understand the risk to benefit ratio of a treatment in order to make an informed decision about whether or not to go ahead with that treatment. That's particularly important in the context of psychedelic medicine because in Australia at the moment, the treatments are costing somewhere between $25,000 and $35,000 for an episode of care. So there's a lot of potential costs associated with this treatment in terms of financial costs, but also in terms of time and investment. So we really need to know whether there are potential harms and how they relate then to the possibility of benefit as well. And the other reason I think this is really important is because while what's published in the literature is largely quite, I guess, reassuring, we are hearing anecdotal reports of harms that are occurring after periods, that are coming to light after periods of MDMA-assisted psychotherapy. And these are only individual cases, so it is not everyone by a large stretch, but there are just some indications that for some people, there might be harms occurring at the end of the therapy that are not being picked up in the processes of the studies themselves. So that's why it's really important for us to understand the side effects. So this was work that was conducted by Julia Colcott, who was a master's student in my group, and also Alex Gurin, who is an early career researcher in my group. And they conducted a comprehensive systematic review and meta-analysis. Well, we conducted a systematic review and meta-analysis of all of the existing trials of MDMA-assisted psychotherapy to date. And that was published in 2024, but it still includes essentially all of the studies that have been published, except one subsequent small open label study has been published for depression, and that was in 2025. But other than that, it's up to date. So there were 13 studies that were identified with a total of 333 participants across the studies. Of those studies, 10 focused on post-traumatic stress disorder. So again, what we see there is that the vast majority of the data that we have to date is on the treatment of PTSD. 8 of those studies were randomized control trials, which allowed us to conduct what's called a meta-analysis. And that essentially is a way of quantifying the difference between, say, MDMA-assisted psychotherapy and placebo-assisted psychotherapy using the results of a number of different studies put together. And of those RCTs, there was 298 participants in those. The sample sizes across the studies really varied. So the smallest one was 3 people, and the largest one was 107. On average, there was 20 people per study, and so these are really very small numbers of people. The 2 largest trials were the 2 phase 3 trials, and as I said, they had around about 100 in them each. And the number of MDMA-assisted psychotherapy sessions varied between 1 and 3 across the sessions. In the phase 3 protocols, which is sort of where MAPS had settled, it was 3 sessions. So this is a bit of a complex figure, but I'll just walk you through it. So this is our data from the phase 2 studies and the phase 3 studies on side effects that were essentially observed under MDMA-assisted psychotherapy versus placebo-assisted psychotherapy, and where they were more likely to happen in MDMA compared to placebo, and vice versa. So the first thing to notice is, the first thing to notice is that everything is on the right of the figure, and that essentially is where MDMA is greater than placebo. So there was nothing that we observed that was more likely to occur in placebo compared to MDMA-assisted psychotherapy patients. So we see much more effects reaching statistical significance in the phase 3 studies and fewer in the phase 2 studies, and that makes sense because essentially we just have more participants in the phase 3 studies. And so what we observed is that there was people were more likely to experience any side effect during medication sessions and any side effect in the 7 days following medication sessions in the phase 2 studies. And these seem to be due to anxiety and jaw clenching or tight jaw during the medication sessions in the phase 2 studies. In the phase 3 studies, side effects were defined a little bit differently. And so what we see is a range of different, what they have defined as treatment emergent adverse effects, which is basically any effect that has been determined by the study physicians as being related to the treatment itself. So if you have a look at all of these are essentially physiological effects, so nausea, perspiration, restlessness, dilated pupils, jaw clenching, etc. And these are more likely to be happening in the MDMA session compared to the placebo sessions. So we did see there was a couple of adverse events that the FDA had identified as of special interest. One was suicidality, and one was cardiac adverse event. And there was no difference between conditions in those two types of adverse event, which I think is very reassuring. And there was also no difference in study withdrawal across the two conditions, again, which I think is quite reassuring. So then we did something which is basically assessing what's called the risk of bias. And I do want to just differentiate between what we would normally call bias in the sort of more general language and what we call the risk of bias for a scientific study. So in this case, we're not saying that the researchers are biased in the normal sense of the word. What we're saying is that there are certain features of the methodology which highlights the potential for there to be scientific bias in the outcome. And there are standard ways of assessing this across bodies of literature. And so we use something called the Cochrane risk of bias assessment. And basically what we found for the randomized controlled trials was that all except one study had a high risk of bias according to this assessment. And one had some concerns, but not high. So then we use something called the grade framework, and this is also a way of, I guess, evaluating an overall body of literature to assess how certain the evidence is based on the methodological sort of features of the studies that are included in the evidence base. So what we found using this grade framework was that the certainty of the evidence about side effects in MDMA-assisted medication studies to date was largely very low or low, with a couple of outcomes being moderate. So again, what that suggests is that we can't really conclude very much based on this evidence because of the nature of sort of some issues that have arisen in the way that the studies were conducted. So what we concluded from all of this was that the side effect profile, firstly, is relatively reassuring from existing studies. So what we're seeing in the side effects that we can detect from the existing studies is very similar to what are the known transient, mild to moderate side effects of MDMA used in healthy populations. So we know that it can produce nausea in some people. We know that it can increase anxiety, et cetera, et cetera. So relatively reassuring. But the problem with that is that the risk of bias, and again, we mean this in a formal structured evaluation sense, not in a sort of more general sense, is high in most studies, and the certainty of evidence is very low to moderate. The other thing we assessed was the reporting of harms across all of these different studies using the consort recommendations checklist, and it was inadequate across all of the studies. So that's the other thing we're observing, is that that we're not actually seeing these harms being reported in a way that is consistent with best practice. And so there are reasons to be a little bit concerned about what's in the literature. We also recently conducted a systematic review of reporting of side effects in clinical trials of psilocybin-assisted psychotherapy for psychiatric conditions. And we also saw somewhat inadequate reporting of harms in that literature. However, it was overall better than the MDMA-assisted psychotherapy literature, and there was an indication that it is improving over time. And so that, I guess, also was quite reassuring. So what we concluded from all of this is that we just need better quality evidence, and we need better reporting of the evidence as well in terms of following those standardized best practice checklists. And the other thing that we really think is important, and this was also really highlighted by the FDA Advisory Committee, was that we do not have any longer term follow-up. And so what we're seeing is that the side effect profile up until that week 13 period, within the 3 months, we're really not seeing what happens afterwards. And as I said before, where we're hearing evidence of some really quite serious decompensation afterwards, it seems to be happening in the period a few months after the therapy has occurred. So one of the issues that has come up is around this question of measurement of side effects, and this is in itself is quite a complicated area. So most studies to date use unstructured assessment or spontaneous reporting, which essentially just means that we say to the participants, how are you feeling? How have things been going? And then if they say, oh, yeah, I've had difficulties, I've been, sad or anything like that, then we take that down as an adverse event. We also use things like some structured tools, like structured tools that measure suicidality, and also measurements like ECGs and blood pressure checks, etc., to collect information about adverse events. It's relatively standard practice in clinical trials of drugs to do this kind of largely unstructured assessment, and this is accepted by the FDA as a reasonable approach to take. However, there's also an argument that this likely underestimates side effects, and that more structured assessment is recommended, particularly in the context of less being known about the safety profile of a treatment. Such is the case with MDMA-assisted psychotherapy and also other psychedelic medicine approaches. We just don't really understand what some of the safety issues might be. And we also don't understand we also know that we have indications that they're quite different from standard psychiatric treatments in some cases. And to date, there is no available structured tool for side effects specifically of MDMA-assisted psychotherapy. So we have developed a tool called the MDMA-assisted psychotherapy side effects tool, or the MSET, and we did that via a Delphi study, and that's currently under review at the moment. So we developed this to do a couple of things. One is that it would ensure contraindications were comprehensively assessed before people started treatment. And that's particularly the case in clinical settings where such assessments potentially are typically less comprehensive than in a research setting. The other piece that was also really important for us, and this is something again that was brought up by the FDA, was how dose titration decisions are made within and between sessions. So in MDMA-assisted psychotherapy, typically what happens is people get an initial dose, then later on in the session, around about 2 hours later, they get offered a supplementary dose. And in the studies to date, this has largely been based on what the patient decides. So they just get offered, do you want a dose? Do you not want a dose? And so there is not much in the way of guidance for clinicians as to whether or not people have tolerated the initial dose and whether it would be useful for them to have that second dose. The other thing that we see in most of the studies is that we have a dose increase between the sessions. So people start on a lower dose in their first MDMA session, and then they go up for the second and third session. And again, there's not really a clear way of guiding clinicians as to whether or not people should go up in those second and third sessions. So then we also wanted to facilitate development of a more robust and comprehensive evidence base on the side effects of MDMA-assisted psychotherapy, both in terms of trials, but also in terms of the real world. And the fourth thing was again highlighted by the FDA, which is how do we know when it's safe for someone to leave an MDMA-assisted psychotherapy session? So there does need to be some kind of standardized discharge criteria, and we established that in this process of developing the MSET. So how we did this was we first obviously did the side effect systematic review and identified the known side effects of MDMA-assisted psychotherapy. But then because we've already highlighted the fact that that's likely to be an underestimate of the side effects of the true side effects, we also then reviewed items from a range of different measures, psychiatric symptoms, known drug effects, altered states of consciousness, side effects of meditation. And then we put all of these together into a draft MSET, and then we used what's called a Delphi study to revise the MSET over a series of online consultations to establish what items should go into the final version. So a Delphi study is basically a study where you consult the oracles of Delphi, and the oracles are experts in the field identified in some way. So in this case, we had 12 panelists. 6 were people who had published in the field of MDMA-assisted psychotherapy. 6 were people who had published extensively in studies involving acute administration of MDMA to humans, so neuropsychopharmacology. And we got an acceptable response rate there. So what we have here is now a screening tool, a baseline assessment, a tool that can be used during acute treatment at the beginning and then throughout the session, and then a follow-up study that allows us to systematically assess side effects over a period of time. So we expect there to be adaptation of this. It's quite a long instrument, and we expect it to be adapted for particular contexts. We're collecting data in our current RCT, and we also hope that it might be used in real-world settings. And we're currently developing the psilocybin-assisted side effects tool using a similar process at the moment. So in terms of key side effects here, we could use structured assessments and longer term follow-up to better characterize side effects and inform clinical decision making. So I'm just going to quickly highlight this study that we're running in our lab, the Papaya study, which is called Pharmacologically Assisted Psychotherapy for Social Anxiety in Youth with Autism. It's testing MDMA-assisted psychotherapy. It's a triple-blind RCT. And we are we're recruiting autistic youth aged 16 to 25 with social anxiety disorder. And we're recruiting 156 people across 3 sites in Sydney and Melbourne. And in terms of side effects, we are using the MSET, and to date, that's been working pretty well. And we're also using passive scent monitoring, which is standard practice. And we have regular follow-up with these participants up to 12 months. So we hope this will address some of these issues. So now I'm conscious of the time, so I'm going to move relatively quickly through functional unblinding. So this is something that has been highlighted as a major challenge in the field of psychedelic medicine. Functional unblinding essentially means that something is called double blind, but in reality, it is not actually double blind. So this is I believe this is the first phase 3 study from MDMA-assisted psychotherapy. And what it shows is essentially the vast majority of participants in each group knew what condition that they were in. So what that means is that even though it is apparently a double-blind study, it's not in practice a double-blind study. And I think this quote really, and this is a quote from a patient that was in the first phase 3 study, and who was talking about these issues in relation to how this was a problem for what they said about how they were doing afterwards. So this patient said, everything that I read, everything that I heard about was how this stuff will fix you. I wanted to be fixed, and I felt great responsibility. At the time, I felt that if I didn't get better, then the FDA was not going to approve it, and millions of people were not going to have access to it. It was more of reporting how things were getting better because that's what I really wanted, and part of me really believed that too. So this was a patient who subsequently had a very negative time after the study, after reporting that they did really well at the end time point of the study. So functional unblinding is not just functional unblinding. It's the combination of functional unblinding, plus the fact that the outcome measures that we're using are self-report and people know what we're looking for essentially. So they can determine whether or not they rate that they're doing better or not. Something called expectancy effects, which is the degree to which someone believes the treatment is going to have an effect for them, it can be quite important. Demand characteristics, which is the degree to which someone feels pressured to get better for the researchers, essentially. We all know there's been a lot of media hype in this area. And then we add into this as well the impact of the fact that these studies are being run by people who consider themselves to be part of an advocacy movement to change the world. And that puts a lot of pressure on the participants in these studies. So very little has been done in the MDMA space to address this issue. So they have tried low dose MDMA as a placebo, but what has been found here is that this in fact increases anxiety, so causes problems in a different way. So in Papaya, we're doing a range of things to address this question. We have 3 active control conditions, and these are conditions that have medication effects that are overlapping with those of MDMA to try and sort of muddy the water a little bit. We're using D-amphetamine, lorazepam, and diphenhydramine. We also are using a inert placebo to try and separate the expectancy effects from straight placebo effects. We're using modified informed consent with very careful ethical oversight, again, to try and maximize our blinding capacity. We're also formally checking for blinding and measuring and controlling for expectancy effects. We're also being very careful what our staff are saying to participants to try and contain the potential for hype and undue pressure being put on the participants. So in relation to this question of functional unblinding, it is a very hard problem, but my sense is that there are many, many things that we could potentially try that have not yet been tested. So we need to improve designs to help ameliorate unblinding and then measure unblinding and expectancy and allow statistical control as well. So in summary, the FDA decision was definitely a setback for the field. I think it provides an opportunity to address many of the known issues in this research. And these are really tricky issues. It's a hard field to research, but there are many ways that we can try to address these issues. And what my hope is that the next generation of MDMA and psychedelic medicine research would have the potential to improve safety outcomes and demonstrate efficacy more robustly in this field. And this is my team, and thank you.
Thank you, Jill. That was a wonderful presentation. I think you've given us a really good overview of the history of the field, or the challenges in the field, and made some really important steps to improving the way that research is done in this area going forward. So good on you. Thank you. I'd now like to invite John, our panelist, to turn on his camera and mic. Hi, John. I'm about to hand over to you for a few reflections, but just before we get into that, I will remind the audience to pop any questions into the Q&A. We've got a number of really interesting questions there, so I really hope we get time to get into some of the weeds there. So John, if you wouldn't mind offering some thoughts from your experience on the work that Jill has presented.
Yeah, thanks, Alice. Just like to acknowledge that I'm also meeting from Gadigal land and pay my respects to elders past and present, and actually in the same room, same building as Alice anyway. So I'll keep this brief because I think it's going to be much more interesting and fruitful to answer questions. But firstly, to congratulate Jill on her work there and really advancing the field. But at the same time, having good scientific equipoise and not jumping onto the hype of the area, I think is really important. Most of my work's been in psilocybin psychotherapy, but listening to Jill's talk really strikes me. There's so many similarities here and sort of big picture similarities in terms of regulatory challenges, trial design challenges, in particular, thinking about functional unblinding and thinking about measuring side effects. So I'm really happy that you're doing that, Jill, and actually really keen to see the P set because I'm sure we'll use that in our studies as well. So I'll I think I'll just leave it there and we'll just go on to questions, Alice, because I think that's going to be much more interesting. Yeah.
Yeah, sure. There's a great deal of interest here, so I'm pleased you said that, John. There's a lot to get through. So, where should we start? Joshua Garfield has a question around you mentioning harms after MDMA assisted psychotherapy that weren't picked up in the original monitoring within the trials, Jill, and whether you might expand on those harms and when they occurred relative to the administration of the MDMA.
So that I'm aware of, I believe there's around about 3 or 4 cases that have come forward that have been talked about in the media. And these have been people who have felt essentially that the description I've heard of it, which is quite sort of harrowing actually, was the idea that they had, like, someone had undertaken open heart surgery on them and then had just left them on the table with their heart open. And so that they'd gone through this kind of intensive therapy process and that they then just felt entirely destabilized by this process. And once they finished that, everything seemed to be going all right. And then after the therapy was withdrawn, they became very, very destabilized. And so in those cases, there have been cases where the participants were saying that they became quite suicidal afterwards. The problem is that this is not showing up in the literature. So what it's showing up in, in the media. It's also, we're hearing the same thing from psilocybin trials, that we're hearing of therapists saying that they're seeing patients who've come out of psilocybin trials who essentially are really destabilized by the trial. And I was also just recently listening to something that the 5-MeO DMT studies are showing up again with people showing up into therapy with people who are known to have expertise in destabilizing experiences following psychedelics. And so what the concern is that it's the short-term nature of the follow-up, I think, is the real problem, because what's happening is it's happening a few months afterwards. And again, it's by no means everyone. Like, I think it's a small subset of people who are experiencing these problems, but we just don't have a sense of who they are and how it's developed and how, can we identify them before we actually put them into this situation. I myself spoke with someone who was a participant in a trial who described becoming basically unable to function and also extremely suicidal when they had no suicidality in their previous history at all. And that had occurred again after the therapy had been withdrawn. And so it's one of the reasons we are so committed to following out to 12 months, because we really want to see and support people if that happens, essentially, and try and work out who it is that it's happening for.
Yeah. John, did you want to add anything there, about those destabilizing experiences in the psilocybin setting?
Yeah, sure. I mean, we've done 2 trials now. The first trial we did was, different populations, but the first trial we did was for methamphetamine dependence. And we mandated as part of that trial that you had to be having some kind of therapy before you came into the study. Because we accepted that really, this is a fairly short intervention in the sort of big picture of their recovery, and they were only having 2 therapy sessions after the psilocybin. So we really wanted to make sure that the care was wrapped around and that they were reintegrated back into usual care afterwards. And that went pretty well. And then the second study, we didn't do that, and it didn't go as well. So I think, there's one thing about measuring it, but there's another thing about really just anticipating it and knowing that, some people are going to be very vulnerable and fragile afterwards, and making sure that they're safety netted with the right support there, acknowledging that, the therapy and the trial is very sort of fixed duration. So I wouldn't do any more trials in this area without making sure that they're already linked in with some kind of psychotherapy or some kind of support for afterwards as well.
Yeah. And Jill, you've explained that there hasn't been much long-term follow-up in these trials formally, but I wonder if has there been any systematic effort to go back to participants of those trials? And I know you can't do it in a completely unbiased way, but asking about subsequent experiences.
There was, and what happened, unfortunately, was that there was like a 12-month follow-up that was a separate study, so it wasn't systematically following people through. And this data was presented to the FDA from the MDMA studies. And what happened was that the people who started off at higher levels of symptomatology and ended up at higher levels of symptomatology systematically didn't participate in the follow-up study. So there wasn't anything particularly alarming that showed up in those data, but there was a systematic difference in who went into the follow-up study. So again, we just don't really know.
Yeah, it makes it really hard to interpret.
Yeah.
Okay. Okay. So there were also some questions about dose. I guess the first one was just around whether the doses used in therapy are similar to doses that are used recreationally.
So maybe I can talk about MDMA and John can talk about psilocybin. So the dose that's used in MDMA has kind of got like a sweet spot dose-wise where it produces like what we would consider to be prototypical MDMA effects. And so beyond that, there's kind of diminished returns essentially. And so what we see recreationally is people do sometimes use much higher doses, but they run risk of developing problems with them. And what they often do is dose across multiple days or multiple hours, like repeatedly, to try and keep the effect going. So the dose that we use is definitely similar. Like it produces what would be recognizable to someone using it in a recreational setting as an MDMA effect. So it's not like a microdose or anything like that. It has robust effects, but it's not going to blow people out of the water or anything like that. So I guess it's and we spend a lot of time thinking about this dosing issue because we do want to get it into that sweet spot where we're getting those effects. We're not seeing those on the lighter end. We see some of the anxiogenic kind of effects, and on the higher end, we see some more sedative like responding. So.
Thank you, John. Did you want to add in relation to psilocybin?
I think my answer is very similar. There's a dose-response relationship between the dose you give, the intensity of your psychedelic experience. And actually, there's some good correlations between the intensity of your psychedelic experience and your clinical outcome as well. But we see something similar in psilocybin. The lower doses, it's a kind of disconcerting experience if you're in the sort of medium dose range, like 10 milligrams. Most clinical trials have been done with 25 milligrams, which is about 3 to 4 grams of dried mushrooms, but have been up to 45 milligrams. But what you see at the higher doses as well is you either see a lot more anxiety features, or even higher, you get this thing called whiteout, where people just become unaware of what's going on for a period of time.
Yeah,
Mm.
thanks. Okay, another question for you, Jill, about studies comparing MDMA-assisted psychotherapy for PTSD with traditional methods of treating PTSD and I guess outcomes.
So no is the first thing. And I think that's a really big limitation. And one of the things that again is another issue that's come up with the existing database is the psychotherapeutic approach. It's kind of unusual, and the manualized approach that was used by the MAPS in the MDMA studies is really quite unusual and very hard to standardize, and includes a vast array of different approaches, and so it means that it's not an evidence-based treatment in and of itself. So it's not like the placebo condition is in fact an evidence-based treatment. And so what we are seeing now, like we are seeing several studies, our studies using an evidence-based treatment. So we know that there is an active treatment occurring irrespective of the MDMA condition. The study that's happening at UNSW at the moment and in Melbourne looking at MDMA-assisted psychotherapy for PTSD and alcohol use disorder is similarly using an existing evidence-based treatment. So we will get a better idea of this, but a head-to-head comparison would be absolutely wonderful, and I think we'd love to see that. In terms of response rates, the response rates in the phase 3 studies were somewhere around about 2/3 of people remitting. from PTSD, and that is quite a high rate. But then there was a recent meta-analysis looking at remission rates from evidence-based first-line psychological treatments for PTSD, and in studies, and the rates were quite similar. They were somewhere between about 60 to 80% from memory. So, so I think if a treatment is delivered to a high degree of fidelity in a very controlled study group in a clinical trial, then we do get really high rates of remission for PTSD. It's just that a lot of the people who don't remit in those settings are the ones who are being excluded from the trials.
Yeah. And John, I guess from the psilocybin perspective, like any comparative work?
Well, yeah, I mean, this is, I think, what the FDA recommended was the next step for MAPS, actually, was to do, comparative effectiveness study looking at treatment as usual. One of the problems with some of these areas is there actually is no standardized treatment. So, particularly for things like methamphetamine dependence, I mean, depression, you could argue there's kind of best treatments and standards of care, but it's kind of tricky. I think what it's going to come down to in terms of sort of regulatory approvals is you're probably going to need a suite of different trial designs to get evidence from different areas. So, I think what they've said is one's got to be placebo controlled, one's possibly a dose escalation study, another a kind of comparative effectiveness study. So, coming at from different angles, but just reinforcing what Jill was saying is it's a complex intervention because you've got the therapy, which is hard to standardize. Then you've got the drug itself and how many doses do you have? Like, what dose do you actually give over what period of time? So it's really hard to know and expensive to design those trials to kind of answer those questions.
Yeah, absolutely. Okay. And maybe back to side effects. I think that's a really popular question to be asking about here is whether there are differences in both outcomes and adverse events between in the MDMA setting, those that are naive to MDMA versus those that might have had prior experience before coming into psychotherapy.
So that information is not readily available. So we weren't able to differentiate based on the data that was in the existing studies. That one of the problems, again, that the FDA had was the high number of people in the studies that had pre-existing exposure to MDMA. And that I think is just a function of how they were recruiting for the studies. Like it was very public. Everyone knew what the treatment was. So there was selective recruitment of people who were into the whole thing essentially. And so I think that basically preferenced people who had positive experiences with these medications before. We are currently recruiting in a way that we're calling blind recruitment, which essentially means we are trying to get people who want treatment, not people who want this treatment. And so we are just putting out like pharmacologically assisted psychotherapy. So people, if they looked into it, they'd probably be able to work it out. But so they go through screening without MDMA being mentioned at all. And then they go through a second consent after screening in which we do the full consent into the study. And to date, we've only randomized 6 people into the trial, but none of our participants to date have ever tried MDMA before. One of them had never heard of it before. So, we're really recruiting a different population than you recruit if you put websites up saying be part of the movement to get the FDA to approve MDMA-assisted psychotherapy and change the world, which is what MAPS did.
Yeah, it's interesting. It'll be interesting. I know you're only in the early days of recruiting there, but whether it will change or impact on your sort of participation rates, if some people might opt out.
Yeah, and that's definitely a possibility, and we're kind of open. We're definitely open to that. We're sort of like, and we have had a couple of people who didn't end up going through anyway, who said they weren't comfortable going through the screening without getting a better idea of what the treatment was, and that's fine. At that stage, we're happy to tell them. But as much as possible, we're just trying to keep it. We want people who want treatment, and then they make a decision about whether or not they want to sign up for this treatment.
Yeah.
Yeah.
Yeah. Okay. John, anything to add there from the methamphetamine dependent side, I guess?
Yeah, not really. Only to say that, you know, so the question is, is past experience with psychedelics an effect modifier in some way? I mean, it's possible it could be. I agree with Jill. I haven't seen any data on that, but I have, you know, I'd say like probably about half of our study participants in the MDMA study had some kind of experience of psychedelics. Clearly, they'd all had experience of drugs, of course.
Mm.
Um, but yeah, I think it's probably more relevant for some than others as well. For example, things like 3-meo DMT, 5-meo DMT, sorry. The effects come on a lot quicker and they're a lot more intense. So, giving that to someone who's psychedelic naive, you have to do a lot more preparation with them before they actually have that experience because it can be very disorientating and distressing for people. So, I think there's those things to think about. But I agree, I haven't seen any data comparing naive versus not naive. Yeah.
Yeah. Mm. All right, I think we might have time for one more. So I'm going to switch from the research setting to more clinical setting now. So we know that the TGA have approved MDMA for PTSD and psilocybin for treatment-resistant depression. And you mentioned, Jill, that they're really high cost, these medicines. So how is that working in a clinical setting? Who's funding it? How often does this happen?
Not very often. So to date, I think we have about 100. It's been very slow because no one expected it. It was a shock to everyone. And so essentially it started very slowly, and over the last 2 years they've now got about 100 authorized prescribers. They're seeing pretty small numbers of people, is what I'm sort of hearing. In terms of payment, we've just seen I think it's Medicare come on. Not, is it Medicare? Medibank
Medibank.
Foundation say that they'll pay, they're doing a trial of funding it for PTSD, MDMA specifically for PTSD. And the other thing that's just been announced is a Department of Veterans Affairs also saying they'll fund, interestingly, both psilocybin and MDMA for PTSD, which I was confused about because psilocybin is not tested or in any way approved for PTSD. But I think that must have been a media mistake.
Okay, right. So Medibank will fund it for their
It's just a trial. So for their members, it's a trial.
yeah,
So I don't actually know how they're choosing who they'll fund it for and who they won't.
I see.
But we're definitely seeing more funders coming online. So I think probably that it'll be more accessible. But the reality is that as this treatment is designed now, this is not a treatment designed for widespread use. This requires people to really commit to a therapeutic process in a way that I think most people in basic garden variety treatment don't want to do.
Yeah. John, anything to add there? Maybe anything about whether the PBS would ever fund this kind of thing?
Well, I mean, the problem with one of the challenges with this intervention is, it's a mixed medicine and therapy. And so actually the major costs are actually from the therapy rather than the medicine.
Mm.
And that's why it's been a bit of a sort of pharmaceutical bubble in some ways that's burst, because I think most people are realizing it's actually from the healthcare providers that are sort of where the major costs lie. So look, it's conceivable, but I guess one of the concerns is with the current things that are happening and the rescheduling is creating a pathway alternative to registration and listing, which has happened with medicinal cannabis, for example. And there's no incentive then to either, do any trials or to get it listed, right? So as it is, if this is good, if this is actually a safe and effective treatment, um, as it currently stands, only very rich people can afford it because you're looking at for most providers like 15 to 20,000 at least for a treatment course. And so, it might, as Jill said, it might be at sort of more at this treatment resistant population to make it cost effective.
Mm.
Um, but it would be nice to see the work done to actually get it across the line, so that so the access was equitable. Yeah.
Yeah.
Whether that's paid for by the PBS or whether it's a sort of something activity based in hospitals that's funded by hospitals at the state level. I'm not sure what the best approach is, but Yeah, it's an expensive intervention as it stands.
Yeah. Oh, well, unfortunately, that's all we have time for. It's been a really fascinating discussion. So thank you both for your excellent contributions. Thank you to the audience for your excellent questions. I'm sorry we didn't get to them all. We will try and extract them and send them on to Jill in case there's anything there that might be worth following up. Before we close, I would just like to let you know about our upcoming events. So I think we have a break next week, and then the following week on the 5th of March, we have a webinar from Pooja Lajasetti from the University of Michigan, telling us about her research on stigma and access to prescription opioids in the US. So we hope to see you online for that. I think that will be all we can get through today. So thank you. I hope you enjoyed the session, and we hope to see you next time.